And now we move on to the next talk, and that will be by Professor ARUN Jain. And he'll be talking to us about whether contact lens is the mainstay of visual rehabilitation, and if it is, that what are the designs and how well we can improve the visual outcome by contact lenses in cases of keratoconus.
Sound is not okay. So thank you, Rajesh, for having me part of this wonderful instruction course, and I have been given the responsibility to justify that whether contact lenses are the mainstay of visual rehabilitation in keratoconus patients and various contact lens design. As we all know, way back in 1998, this study showed us that almost 75% of patients with keratoconus need some sort of contact lens, and only 10 to 20% need some surgical intervention. And of late, now only maybe 5 to 10% of keratoconus patients need surgical intervention. So, and also we know that at each stage of keratoconus, we have different options of treatment available to us. But whatever type of treatment you give to the patients, you have to visually rehabilitate this patient with some sort of optical correction, be it spectacle or contact lens, because the astigmatism in these cases highly irregular. It is usually not amenable to correction by spectacles. So almost all patients, even after doing some corneal surgical procedure, they will need some sort of optical correction in terms of spectacle and contact lens. This is a busy slide, so these are the various different types of soft, hybrid, piggyback. I won't go into detail all this. We will concentrate mainly onto the rigid lenses because they are the mainstay of treatment to counteract these astigmatism and minuscule or large scale lenses, which where the keratoconus is very advanced and the cone is also very protruding. In those cases, large scale lenses are indicated. So, depending upon the grade of keratoconus, whether the keratocone is mild, moderate, or severe, depending on the K reading and the size, shape, and position of the cone, you will have to choose the contact lens. So, mainstay again, I'm emphasizing is the uh, rigid gas permeable lenses, which may be either in the form of rose K2 and different type of scleral contact lenses. So, depending upon the morphology of the keratoconus cone, you will decide which type of contact lens. If it is a small central nipple cone, it's easy to fit with a contact lens. But if the cone is little large and oval, it's more challenging to fit a contact lens in these cases. And if it is still large and involving almost whole of the cornea, it will typically warrant the use of scleral type of contact lenses. So diameter of the contact lens is based on the location of the cone, its size, and the steepness of the cornea. So soft toric, as I've already highlighted, they are easy to handle and they are comfortable, but they will work only in early keratoconus cases, and usually they drape over the corneal surface, so they won't correct high degree of astigmatic power. So indication will be only early keratoconus, RG or where RGBs are not tolerated, and spherical scleral contact lens have failed to mask the corneal astigmatism. So coming to the rigid gas permeable lenses, these are usually the first choice for correcting the irregular astigmatism and vision improvement, because in keratoconus what patient wants is stabilization of progression and the vision. These are the two main concern of from the patient's point of view. And nowadays very highly permeable oxygen permeable lens materials are available. So they are not very expensive, though they are expensive, but not very expensive, and they give a very good vision. And if handled properly, they may last for at least 2 years. And but the downside is there is a little lower initial comfort, and but they are suitable for high corneal surrender and irregular cornea. And this is the latest classification given by the Scleral Lens Education Society, which is internationally recognized. And there is subdivision into the corneal type, corneoscleral or full scleral lenses, depending upon the size of the contact lens and where they are resting. So scleral are further divided into smaller and large scleral lenses. So fitting keratoconus has been traditionally complicated. You need a lot of skill and experience. There are so many different types of designs and sets available, and a lot of sheer time is required. So you have to have a dedicated optometrist working with you. And rose K design is the most common lens prescribed for this type of keratoconus patients. And what is the special about it? It's a tri-curve lens. Standard lens have a very fixed optical zone, and they do not fit the cone shape of the keratoconus. And there is an unwanted pooling of the tear around the standard lenses. But these rose K lenses, they are tri-curve lenses, fits and snugly over to the cone of the keratoconus. And you have to have an optimal fit. And this has to be, I am not going into details of fitting philosophies, because that is a that will take a lecture in itself. So there should be a light feather touch in the at the apex of the cone is desired. So there should be no and mid peripheral bearing, as well as the edge lift should be quite adequate in these cases. And this is a one representative case of 35-year-old male who had a high astigmatism of 5 diopter in both the eyes, and with spectacles she was only improving to 636 and 618. So this is the pentagram of the same patient. And this is the way you go about selecting the lens: the base curve, diameter, power, edge lift, design, material, tint, and with and without sort of exchange if the edge lift is more. So all these parameters has to be verified, and then you place a final lens order. This is how you record the findings on a paper. And this is the same patient with the contact lens, and there's an optimal central feather touch, and there's a mild pulling, mid peripheral bearing, and adequate edge lift in this case. And this is another case with the 6 diopter and of astigmatism. Other eye was correctable this was correctable to 6.6. And so these are again same parameters, but here the keratocone is even more advanced, 11 diopter. This lens, this case was fitted from outside the ordinary lens. So what has happened is there is an apical bearing. Patient has developed apical scarring onto the cornea, and you can see it's a flat, and it leads to scarring on the cornea. So we changed it to rose K. So there is a minimal feather touch and a mid peripheral bearing and the edge lift. So the fitting of the contact lens is very important in this case. This is the first paper from India we published on real scale lenses, which is based on topographic finding. Even the inventor of rose scale lens, he wrote to us that he really liked the paper. He's from New Zealand. And coming to the scleral another 3 4 slides only. So as we already discussed, if the keratoconus is advanced, the cone is very large, we have to use these scleral type of contact lenses. But they are expensive. They do improve the vision drastically, but they are a little expensive, and the lens handling initially people find it difficult. And we have to know the lens anatomy. In these cases, there is a central clearance zone which should be clear of the cornea around 150 to 250. Then the independent limbal independent transfer zone offers independent customer. It has to be customized. So again, I am not going into the fitting philosophies. And this is the scleral landing zone. which aligns onto the sclera. So what we do is, when we are doing the assessment of these lenses, there should be optimal clearance, which should be around 100 to 300 micron, and it should be tapering. It should be tapering towards the periphery, and the edge lift has to be proper. There should be 50-50 rule should be followed. It should not be impinging too much onto the there should not be too much of edge lift, or there should not be digging in of the edge of the lenses that will compromise the ocular surface, as well as patient will have discomfort. So just example of this case, patient had -8, -6, 636, this is pentacam. So we fitted with the scleral lens. You can see the clearance on the OCT. Kasha is quite helpful even in evaluating these cases. So you can see the fluorescent pattern which is tapering, and this is another case of again this thing. And even post keratoplasty, you have, if there is a very high astigmatism, you have to fit these cases. So the conclude, at whatever stage of keratoconus you are, there are different options. So in initial stages, you have the option of C3R. You have already heard all the speakers: phakic ICL, toric IOL, TPKR, and in the later stages, you have the option of lamellar or penetrating keratoplasty. But whatever you do, you have to give them a optical correction in the form of spectacle or contact lenses. And I do say that contact lenses are the mainstay of treatment as a supplement to the various therapies we give to the keratoconus at different stages of the treatment. Thank you so much.